is one of my best friends and my colleagues, Dr. Sevgi Kalayoğlu Beşışık, talk about COVID immunity post-recovery.
Thank you very much, Mustafa. Can I start?
Yes.
Yeah.
Yes, you can. Thank you.
Yes. Yes, I am Dr. Sevgi from Istanbul University, Istanbul Medical Faculty. I am working as hematologist, and I am also the director of the same institution, Blood Center and Therapeutic Apheresis. Before I start my talk, I wish to say that this event is very important because we have to continue to share our experiences and observation in this era. We need more data from more countries. I dedicate my talk to all professions who passed away during this pandemic, and I start my talk. If I can do it, okay. As we learned that in 2019 there is outbreak in China. We heard this. As we are sitting at home or working in hospital, this is a far news for us. We heard this on TV channels or web pages. This was a terrible condition, but it was far from us. And China reported that this is a fatal disorders, results in pneumonia, and we could not find the etiologic agents. During the 3 months, who was silent, I think, until March 2020, who announced COVID is a pandemic condition. During these 3 months, we learned that there are cases in neighboring countries near to China, near to us, such as Iran and some European countries. So we are learning to prepare prevention for some disinfection or others, and we prepared some protocols for hospitals until who announced them. We are already ready in our hospital. And China reported that the virus is a new virus and share some genomic material homology with recent coronavirus. They are experienced in 2002 as again an outbreak, which are called as severe acute respiratory distress syndrome coronavirus. So they named this virus again coronavirus, novel coronavirus 2019. The first name was so. And after this announcement, we developed some changing in our life. New solutions has become in our hospital, in our microenvironment. So the people are working a part of health physicians are helping to produce some masks and other equipments, such as private fabrics or vocational schools. And some factories are started to make mechanical ventilation machines. And another important thing is health authority invites very so many specialists to Zoom meetings every day, sometimes 2 times in a week, to share and to prepare guidelines in as belonging to Turkish health authority. They are mostly specialists in ICU or infectious disorders, but there are also hematologists between them. And maybe I have to mention the principal management program was contact tracing, as Mustafa has mentioned. Some local health authority called the people who are exposed to COVID patients. They are isolated, and 14 days they are called every day. And a treatment guideline was established, if I not false remember, in the last week of March. Until that time, we saw the patient in the afternoon and come to the hospital in the morning. The patient was passed away. I think the main medicamentation in our guideline was anticoagulation prophylaxis, as Mustafa mentioned. All patients had received anticoagulation, but we have not changed. If the patient came to the hospital and received anti-aggregating treatment for ischemic heart disease or another, we do not change it, but give all patients with the diagnosis of COVID-19. And the other important thing was anti-cytokine treatment. If indicated, we have given mostly anti-interleukin 1 beta, but also tocilizumab. And we have to give our data among the Turkish physicians, also local hospitals data we have to give. But I think the mortality rate is low, and this can be related, but I don't think so. This can be related with virus virulence, but maybe early assessment of the disease and early supportive treatment for virus may help our patients. So for SARS-CoV-2 virus, we know all of that, us. It is a RNA virus and encodes very important proteins. 4 of them are structural proteins, and spike protein is important because spike protein is the binding protein to the target cell. Spike protein, so-called as glycoprotein, has 2 subunits. S1 is the outer one and has a receptor binding domain, and S2 is a transmembrane unit. It changed during binding, so can give the opportunity to insert the virus in the target cell membrane, and in endosome buildup, which is followed by virus replication and beginning of immune response. It is strange for me. Yeah. the target receptor for S protein, S glycoprotein, is angiotensin converting enzyme 2, which is harbored on many organs, but abundantly harbored on lungs, but is expressed also in heart, also in intestine or in kidney. The spike protein is the primary determinant of cell tropism and pathogenesis. If you remember, S protein and angiotensin converting enzyme build up a complex, so the enzyme level is reduced, and we will discuss a lot of whether the patients of receiving angiotensin converting enzyme inhibitors are at risk for COVID-19. It is difficult for me to progress. Yeah. If the virus complex with this enzyme is insert the membrane and became as endosome in the target cell, there are so many cytokines released, mainly interferon 1 and pro-inflammatory cytokines, and mainly interleukin 1 beta. So the result is an death of cells, but this is another very different type of death, inflammatory form of cell death. This name is proptosis. So every step bring another drug to stop this process. And for ACE2, we know that if you bind ACE2, the angiotensin 1 and angiotensin 2 are free. So this results with renin-angiotensin stem activation, which is fluid and electrolyte imbalance, and also vascular permeability. This also with a consequence with a pro-fibrotic response. And the virus is replicated, and first immune system step is innate system. So innate system is consisting by NK cells, neutrophils, and monocytes. Neutrophils are very important cells. They are secreting some cytokines, some chemokines, so they are attracting other immune cells to the local microenvironment. And if you compare the non-survivors COVID patients with survivors patients, you will see that the non-survivors has higher neutrophil levels related with these immune response. And for adaptive immunity, by the way, I have to say this activation of innate system also activate complement system. Complement system is also another inflammation resulting activation, but adaptive immunity became also to the immune response, sometimes Turkish. In adaptive immunity, cellular cytotoxicity and humoral immunity start simultaneously. I have to mention the important thing is during that time, we know that monocytes are very important to present antigens to the cytotoxic T cells. But during COVID-19 infection, monocytes have reduced major histocompatibility class 1 expression. This is also with the result of exacerbating of the COVID-19. This is also valid for the elderly patients. By the way, B cells also starting to producing antibodies. Not every patient is with hyperinflammation status, but overwhelming immune cell activation, maybe we can say insufficient anti-hyperinflammatory response, or imbalance between inflammation and anti-inflammation response results the clinical spectrum very severe acute respiratory distress syndrome or other multi-organ failure. During that time, we learned that all of them observed lymphocytopenia. Lymphocytopenia is mainly among CD4 positive and CD8 positive T cells, but the ratio is stable, normal, and naive T cells are increased. On the other hand, memory T cells and T-regulatory cells are decreased. They are also important for the establishment of hyperinflammation phase. Among B cell activity, there is no major impairment in B cell activity, I have to say. This is important to maybe treat the disorder. For treating disorder, we mainly give the patients supportive treatment, anti-cytokine treatment, or anticoagulant treatment. But now there is another option to give the patients antibody. We all know that antibody treatment is our life as hematologists. We mainly use them in non-infectious disorders. This antibody response in COVID-19 can be separated in two groups: neutralizing antibodies and non-neutralizing antibodies. Neutralizing antibodies are the blocking antibodies. They are binding to S protein domain, receptor binding domain, so they are docking the virus to enter to the cell, and also they are building an Fc receptor to bind other immune response cells to the virus. So they are resulting antibody-dependent phagocytosis, antibody-dependent complement cytotoxicity, or cellular toxicity. But there are also non-neutralizing antibodies. They are specific for this virus. They are coating the virus, but they are not blocking the virus. That is very important. With coated virus can recognize by macrophages, and macrophages take the coated virus in the cell, so the macrophage will be infected and facilitate the infection spreading among the body. This is very important for us, and non-neutralizing antibodies can exacerbate the inflammation status in the body. And we don't know the duration of neutralizing antibodies in the body, but we know that 70% approximately developed neutralizing antibody. The duration is important. There are some data such as 4 months or 6 months, but not established data are not yet in our records, and we know that high titers of neutralizing antibodies is with worse clinical outcome. This is also related with hyperinflammation complication. We know the first response is IgM immune response, but in this status, IgM and IgG appear earlier, and the titers is highly very high in patients with severe COVID disorders. Now, for convalescent plasma, according this neutralizing antibodies, we can guess that antibody treatment can help virus infection, because other treatment modalities are mainly supportive treatment. Maybe some antiviral can help the virus infection. Convalescent plasma treatment is not new. It's started in 19th century, especially for diphthery patients, but that time there was the only way to get some serum from the patients who are recovered from a contagious disease. There are no advancements for antimicrobial treatment. So just recently, for other coronavirus infection, there are some experience and showing us some clinical benefit from convalescent plasma, and also reduced mortality for SARS or for MERS or for influenza infection. There is some debate in Ebola, but we know that convalescent plasma, immune plasma from recovered patient, can have a role in treatment as blocking of viral entry to the target cell and having a role in the treatment. Now, it is very easy accessible, and as you mentioned, there are so many people coming around as recovered from COVID infection. So we can take and storage, collect and storage this convalescent plasma, but we have to know that this type treatment is not standardized. So we don't know that for every donor, what type of this antibody, how is the neutralizing antibody duration in vivo. This is not standardized. And the other thing is the duration of this antibody is short in the recipient, so we have to find another solution for this modality. This plasma is polyclonal antibody having plasma, so maybe this is beneficial, maybe reduce the benefit. We can imagine the role of convalescent plasma can be first as prevention, or can be secondly for early of the illness, to block the viremia. For example, you have a person has a contact exposure history. You can use this convalescent plasma to prevent the disease evolution. We know that in our medical life for some viral infection, but we don't know is it working for this goal. And another important thing, this guideline administered by our health authority, by also by FDA and also by European Commission, is recommending to give convalescent plasma when the patient is going to the birth. This is a biologically natural time, I think, because the goal is to blocking the virus replication. And the other phases are related with hyperinflammation. But in my country, also, the convalescent plasma indication is with high hyperinflammation phase and with high biological markers when the patient are going to ICU and so on. I think it is better in early period to use this anticore type. Is there any adverse effect of convalescent plasma? Maybe all convalescent plasma donors are screened, such as blood donors. So we know that female donors are with trolley risk. So we don't choose female donors, or some blood banks screen for anti-HLA antibodies. And we have in my blood center pathogen inactivation machine, but FDA also recommended it for other viruses and maybe more safe using of convalescent plasma. Another important thing is you give an immune response, you transfer an immune response to your patients. Maybe this will reduce the self-immune response of these patients. This is also an interesting question for the patients. The last slide of my talk is for the future. We know that there are some monoclonal antibodies in some disorders. Maybe monoclonal antibodies are more will be more effective in disease eradication. Also, maybe vaccines will results more persistent antibody response and cellular immunity response for these patients. So I finish my talk and say, yes, we lost so many things, but maybe we learned something what we lost during this time.
Thank you so much. I just would like to remind the speakers that we have only 15 minutes for the lecture, so we can move on to the next speaker. Dr. Mittelman talk about the effect of erythropoietin in the for COVID patients. It's a very interesting topic. I eagerly wait for your lecture. Please, Dr. Moshe.
Dr. Moshe?
Can you hear me? Would you please turn on your microphone? Turn on your microphone, please. Moshe, can you hear me?
I hear you very well.
Fine. Okay, that's great.
Okay, great.
Okay. Thank you so much. Okay.
Thank you, Mustafa, and I really want to congratulate Professor Birol Govenk and Onur for this great initiative. Since I am neither a virologist nor epidemiologist, I would not talk about the disease itself. What I would like to do is really, you see, I will not talk about the disease, I will not talk about beer. What I would like to do is to talk about two topics. The main one is to share with you some thoughts about what happened in our country during the pandemic, and then very few slides about the potential use of erythropoietin in this disease. About several words about Israel to those of you who are less familiar. This is a country with 9 million people. The ethnic groups are mainly Jewish people, 75%, and Arabs, 21%. I would like to emphasize that the population is relatively young. This is probably part of the reason for the differences as opposed to other countries. 90% of the population is younger than 65. The area is quite a small area, 20,000 kilometers. So this is relatively a very crowded country. And as for, I would like just to show you the pointer. Can you see the pointer? No? No, I can't use the pointer. Anyway, this is a very crowded country. Economy is quite good with GDP per capita of more than 40,000 people, $40,000. Employment prior to the pandemic was very low, about 4.5%. This is what was the case in the beginning. Now I'm trying to see. Okay, yes. Now, a few words about the medical system in Israel. Medical system in our country is mainly public. 99% of the residents, even if they are not citizens, foreigners, foreign workers, illegal people, whatever, they are all insured by one of the 4 insurance companies. There is a very good, well-distributed community system. Medicine is quite modern with a very developed preventive medicine. There are more than 30 hospitals, more 6 or 7 medical schools, and science is also quite developed. I guess people are well familiar with Weizmann Institute. There are 6 Nobel laureates that are Israeli over the last 15 years, and life expectancy is around 85 years. I'm telling you this because this is part of the explanations for what happened later on. Now, the COVID-19 in Israel in numbers. The first patient was diagnosed in February 27. Totally, till 2 days ago, we had 16,000 patients, which is less than 1% of the whole population. So talking about all population immunity is irrelevant in many countries, including ours. And the dead and the patients who died, the number is 939, which is about 1.4, 1.5% of the patients who were defined as sick. And since we are doing quite many labs, I guess that this is quite accurate number. Now, the steps that were taken in the health system in late February, early March, all routine activity was stopped. Corona departments were established in every center in Israel. Physical isolation units were built, with physical barriers, and electronic monitoring system were redistributed. Most of the teams underwent training. Equipment was found not to be enough, so there was many projects of purchasing new isolation material, protective measures, ventilators and respirators. It's a type of mistake, respirators. And there was also arrangement to do lab work, including laboratories, which are usually scientific labs, and were recruited and also volunteered to do lab work for the corona. There are other players, and now I'm moving on to non-medical players. The Prime Minister got very involved and conducted everything. The Ministry of Health was involved, obviously, Ministry of Treasury, other ministerials. There is the National Security Council, which dropped all that they were doing in regular daily life and started to work on that. It was clear-cut that only large organizations such as the Army can take care, and the Army was involved in taking care of the population, providing food and everything. And there was a pandemic team which was in charge of everything. Interestingly enough, there were other consultants, such as obviously epidemiologists and others, but in my opinion, the more interesting point was many scientists, such as mathematicians, physicists, computer people, people who are interested in developing models to try to predict what's going on, what can be predicted, and they were really helping the system. Other things that happened, it was a national emergency situation which was declared by law. Airports were closed in March, very early. In 5th of March it started, and in 7th or 8th of March everything was closed, which was eventually a successful step. The patient distribution all over the country, you have to remember that the country is very small, so it's not difficult. Patients with mild disease were referred to hotels. There were several hotels that were taken by the government, and people were taken to these hotels. The contacts were asked to be isolated, and there were several facilities to maintain and to supervise contacts. And the public was educated to keep social distance, no close contacts, to change the behavior, as I guess in many other countries. And unfortunately, all meetings, including medical meetings, canceled. I was lucky to organize the International MDS meeting in March 5-6, which was probably one of the last ones to be organized in long time. We got daily updates every day in the television. High-risk populations such as people above 60 years old. I never saw that I myself as in risky population, but I learned it during this pandemic. And we paid attention to nursing home quite late. I'll get to that in a minute. There was a lockdown which lasted 6 weeks, which was really terrible, too much to my opinion and to many others. Everything was closed, school, universities, restaurants, sports, everything, I guess similar to other countries. And yes, the telemedicine and working online really proliferated. A few words about hematology in the COVID era. It's pretty much similar to what other speakers have already mentioned, so I'll be very fast in that. The activity decreased significantly. Many of the people were recruited, especially the young physicians recruited to work in the corona departments. And since most patients are elderly and at risk, they were afraid to come. They were also advised not to come. And we had to do telemedicine. And I think some of the previous speakers explained it very nicely. Also, several other things not really in the medicine happened. And I think it's very interesting to share these thoughts. Many labs developed, including scientific lab that volunteered to work for corona. In medicine, many people, even outside of the field, started to do many interesting things in this area. Trials were going on. The previous speaker already mentioned the plasma for convalescence. Also, a study was done in our country, and the impression is that it was very helpful, but the data are not published yet. And the equipment, including reproduction, factories that were dealing with other issues started to produce ventilators. Interestingly enough, there were some other things such as adopting efforts. People started to adopt lonely elderly people, provide them food. This was very nice. And we started to have a public debate whether the government is right or wrong in all these steps. It is clear now that at least in 2-3 things we really missed, and this was a mistake. Number one, we did not do enough tests. Although we did, and we still do more than 10,000 labs, 10,000 samples per day, which is not a small number, we still believe that probably it was too late and too few, because if you do more tests, then you can probably screen healthy population and probably isolate the right people, and this can allow you to allow the other subgroups to be free. The second thing is that probably we did not use enough the excellent community system. We used too much the hospitals and the Red Cross and not enough the community system. And the third mistake, we probably did not pay attention enough to nursing homes and to crowded people. I probably mentioned that 10-15% of our population are Orthodox religious people, and they live in a very crowded community. And some of the foci for the infection were among these communities as well as in the nursing home, and it took us too much time to detect it. The outcomes of this a pandemic and the steps taken in our country, I can split it, to the good, the bad, and the ugly. I guess that most of you are familiar with this movie 15 years ago. And I learned yesterday that Clint Eastwood yesterday was 90-year-old. So the ugly, I would say, is that life in the lockdown was terrible, and our routine life really changed. And we learned again how much we all love our routine. The good thing is that really the pandemic was controlled. The bad thing is the high price, and I should say something about which is not really medicine, but we all should be aware of it. There is the economic deterioration in many countries, including our countries. We have today more than 1 million unemployed people, which is about 25% of the population. And yes, the other non-corona medicine was really in a deadlock. I mean, I can give you many, many examples. I guess since many hematologists are here listening to us, everybody can give his own experience. I can just tell you about two of the last patients. One of my MDS patients who really became worse and did not pay attention enough for that, just because he thought he cannot come to the hospital. And when he came, we found that he is already having acute leukemia, and we could not save him anymore. The other one is a patient with multiple myeloma who really had also some bad signs. And when he came, we found that he has irreversible renal failure. So these are just two classical examples for the non-corona medicine that remained behind. In general, we compared with other quite succeeded. You can see here the blue column suggesting that our casualty, the number of deaths is really low. Why is that? If you hear the official people, they would tell you that they took the right steps. Timing was everything, including early steps, good coordination, credit to the health system. I can probably agree with the last one. About all the other, I don't know. There are probably other reasons which I put, in question mark. Maybe the young population, the warmer weather, people are thinking that maybe there is a variant of the virus, and maybe just luck, maybe all of the others, who knows, remains to be studied. What about the future? Obviously, if we want to prepare ourselves for a future problem, we will have to strengths to make our system stronger. We will have to start tests from the beginning. We will have to increase the use of the community system, improve the coordination, and hopefully we will have better drugs and maybe also vaccines. I would like to switch very quickly and to spend 2-3 minutes to talk about possible use of erythropoietin. Now, I guess I am not telling anything new about the virus. Everybody is familiar, but the IL-6 is one of the major players in the cytokine storm that is characterizing the advanced stage of coronavirus disease. And we have been involved in research on erythropoietin now, I guess, for 30 years. And again, I don't have to tell this audience that erythropoietin is a very effective anti-anemic agent, hormone. What I would like to mention is that about almost 20 years ago, we published in PNAS a paper showing that in addition to the erythroid effect, erythropoietin has many other effects, including immunologic and anti-cancer effects. And we continued to investigate these immune effects of erythropoietin. And in one of our papers, we showed, here you can see patients with multiple myeloma. The left column are healthy people. The middle column represents patients with multiple myeloma who were found to have high serum IL-6. And the right column are patients with multiple myeloma treated with erythropoietin for their anemia. And sure enough, you can see that IL-6 is reduced in these patients. So why not to use this relatively benign agent in these patients? And in fact, there is at least one report from Tehran in Iran describing a patient who received erythropoietin. He was very sick, received erythropoietin also in addition to the other treatment, and recovered in a very, very astonishing way, suggesting that this may be the case, and also suggesting that, again, as we always say, international collaboration and international exchange of ideas is always useful. So yes, we have started a protocol with erythropoietin in these patients in the severe disease. It's still too early to report the results, but we are very encouraged about this possibility. And with that, and with the interest of time, I will finish. And let's all hope, again, thank you the organizer, and let's all hope that very soon we will get again to better times. We will all be able to go on the beach and visit each other. And thank you again.
Thank you.
Thank you.
I really thank you, Dr. Mittelman. We can move to the next speaker, Dr. Francesco Saglio from Italy. Yes, please.
So good afternoon, everybody. Thank you very much for having involved me in this event. Fortunately, as pediatricians, we didn't face a very hard time during the COVID-19 outbreak, since the number of pediatric affected patients was in all the casuistics pretty low. However, I would like to present you a case of a patient developing this infection in the early post-transplantation course, because I think that it can give us the opportunity to make some reflection about the management of the disease in such a complicated situation as is the early post-transplantation disease, the post-transplantation course. So the patient is 19 years old male affected by acute lymphoblastic leukemia that was diagnosed in June 2019. He was treated initially to the protocol Gimima 2317, that is a combination of blinatumomab with the chemo. And in his past medical history, there weren't a lot of issues related to the infection. Just a nasal swab positive for gram-positive bacteria, an episode of sepsis that the patient easily recurred sustained by Pseudomonas, and then pneumonia without any isolation. When we received the patient to perform the transplantation in February 2020, we started our regular pre-transplantation workup, and at the respiratory system we didn't find any big abnormalities. The chest CT scan was normal. There was just a light obstructive deficit with a Tifenol index of 82% with no response to salbutamol, a regular diffusion, and about the cardiovascular system, the EKG was normal, and the heart ultrasound showed no abnormalities with an ejection function of approximately 68%. All the other systems and organs were completely normal. So the patient was admitted to our inpatient clinic on 24 February, and the day he was admitted, he complained about some nasal secretion. So at that time, the problem of the coronavirus infection wasn't still an issue in Italy. So actually, we tested him for main respiratory viruses, but we didn't include the SARS-CoV-2 into our panel, and the test resulted negative. The patient had his stem cell infusion on 5th of the March, and the very early post-transplantation course was regular. When the white blood cells started to arise and the patient and the engraftment process started, the patient started to complain about cough and fever, as you can see here. And as you can see here, we ran our routine test, and after approximately a week, the patient still was in a situation with the cough, light reduction of the saturation of the oxygen, and some peaks of fever. The chest X-ray that was performed on the 18th of the March actually showed a kind of congestion at the hilus of the right lung, together with some condensation in the left lung. So we decided to perform a CT scan that actually showed some areas of congestion, bilateral, but mainly at the left lung, that our radiologist reconduced in first hypothesis to a bacterial infection, in second hypothesis to a fungal infection, and as a third possible explanation to a viral process. So we started the broad spectrum antibiotics, and we waited for the results of the culture. In the meanwhile, the patient was still under oxygen that was delivered with low flow devices, just nasal cannula, 2 or up to 3 liters for minutes. So it's something really light. And after a week, when all the cultures came back negative, the patient had the saturation of the patient got worse, and since at that time the problem of the COVID-19 outbreak became relevant also in our country, we tested him for the SARS coronavirus 2 that resulted positive. So fortunately, the patient at this moment was able to leave the transplantation ward, and he was transferred to the place in our department that was organized for the admission of the COVID patient. As soon we had the results, we also started heparin that was firstly given by IV. It was sodium heparin, because we were concerned about the low number of platelets and possible problems related to the subcutaneous injection of the drug. And after a couple of days, we obtained from Gilead the authorization to start remdesivir as a compassionate uses. These are in this table. I have tried to resume all the data about the ventilatory support that we gave to the patient. As you can see, the patient was in a situation where the blood oxygen saturation wasn't so bad as the blood gas test showed here, and with a relatively low concentration of oxygen. In considering that we have some experience that usually these patients in their early post-transplantation course can benefit from administration of oxygens delivered by positive pressure, we started the CPAP that we maintained with a level of PEEP around 5 up to 7.5 centimeters, water centimeters of pressure. The patient on 10th April repeated chest CT scans that showed a worsening of the situation of the lung. At this point, our radiologist suggested that beside the coronavirus infection, also a fungal infection was likely to have occurred, especially in this area that showed initial signs of excavation. And so, in consideration of the increased request of oxygen, the patient was transferred to the ICU dedicated unit. He was admitted in the ICU on the 15th April, and we started a ventilatory support with a non-invasive ventilation with in-pressure support with a PEEP of 7.5 water centimeters and a pressure support of 8 up to 12 water centimeters, and with a VO2 around 40 up to 60%. We consulted with the anesthesiologist that suggested us to prone the patient, and also in consideration of the condition of the patient, in order to perform the prone position, we started also a light sedation with the propofol and Dexa. After 10 days of therapy, we stopped the therapy with the remdesivir, and in the meanwhile, the patient experienced an EBV reactivation, and so we had to start rituximab. In consideration of the condition of the patient, we slightly modified the schedule of the administration of this drug, prolonging the interval between the single doses that from 7 days was brought up to 14 days. The patient had previously one attempt to reduce the inflammation in this lung by hydroxychloroquine that was stopped, and later it was introduced the steroids at a dosage that is something in the middle between an anti-edema and anti-inflammatory doses. In the same time, we asked the company the authorization to use ruxolitinib as a compassionate uses, and we choose a dose that has been previously said. It was the doses that we usually use in the GVHD. The dosage was lowered because the patient in the meanwhile was treated with the drugs that can have an interaction with the cytochromes. So we have decided to bring the dose as low as possible. The patient continued to be treated with the antithrombotic therapy that was heparin. In the meanwhile, fortunately, the platelets count arose, and so we were able to give him a low molecular weight heparin. The patient also received broad spectrum antibiotics, and this is a mistake, sorry, and isavuconazole for the treatment of the pneumonia that was also possible related to the a fungal. Obviously, we checked him for IgG level, and we replaced them when the level was under 500 milligrams for the deciliter. Fortunately, with this conservative approach, the patient on 7th May was discharged from the ICU. He came back to the general ward of the COVID ward, and also the CT scan that was performed a few days later showed an improvement of his lung lesions. The evolution, so after approximately 2 months, we were able to test him negative for SARS-CoV coronavirus 2 on the nasal swab. We started a respiratory rehabilitation in order to avoid the fibrosis that has been described in his patient, and the patient also was treated to physiokinetic therapy in order to solve some muscles problem that he had related to the long staying in the bed. The patient was discharged just on Friday, so on day plus 87 after the transplantation, and now all the assessments are regularly planned as outpatient. So what we had to check if our approach was useful in treating him. On April, the American Society of Stem Cell Transplantation and Cellular Therapy published these guidelines that actually gave us some confirmation about what we have done in our patient. And even if we weren't able to enroll him in any clinical trial because there wasn't the opportunity. All the transplantation was an exclusion criteria for all the trials that were run in COVID patient. We were mainly able to use these drugs that were reported as potentially useful in the treatment. So what the reason why I have chosen to present this case in such a meeting, web meeting, has been that I think that it gives us the opportunity to think about the importance of the knowledge of this disease physiopathology, the use of the heparin and antithrombotic effect of the all these problems related to the inflammatory phase of the disease let us decide and take, I think, the good decisions in order to make the patient survive. The other really important point that I would like to stress out is the importance of the knowledge of the patient. When we discussed with the anesthesiologist about the opportunity how to correctly ventilate the patient, they were more oriented into patient. We were able to make them avoid the intubation. I think that could have been a really issue for our patient. And the third point is the importance of the multidisciplinary in treating these patients, involving the anesthesiologist, the bone marrow team, and the nurse, all the people involved in the rehab. That I think that is the really key to the successful treatment of kind of patient. This is my last slide. I'd like to thank you all for the attention, and I would be happy to take any questions you might have. Thank you.
Thank you so much for your presentation, Dr. Saglio. We can also move to the next speaker, Dr. Hannah. Hi again. How are you today? Yesterday you were so fine. You look great.
Yeah, thank you very much, actually, for you and the organizing committee to give me the chance to be with you today. I'm waiting for allowing me to share screen or to dispose my presentation. Anyhow, what I'm going to speak about is not purely what's going on in Egypt, but I'm going to revise with you our learning curve over the last few months since the discovery of COVID-19 first case, and how did we identify and build our experience. In Egypt, we are in the ascending curve with Corona. Yesterday evening, our cases were 23,500 almost, with a mortality rate of 5.8 and recovery of 24.2%. In the last few days, we are having more than 1,000 cases daily. Still, we are adopting using hydroxychloroquine for our patient with COVID-19. And we are expecting to receive our first batch of remdesivir in few days to start treating our patient with that drug. And we are using actually convalescent plasma from recovering patient or cured patient to treat cases of COVID-19 in different stages and to see the most effective stage. We will see that when we reach our peak and to start to know what's going on. The first part of my presentation is concerning how the disease and the red blood and the blood cells, different blood cells, are affecting each other. The first thing which have been reported is the morphological changes which happens in the blood cells, particularly the white blood cells, with a lot of changes in the nucleus of the neutrophils, in the cytoplasm of the neutrophils, and starting of expansion of the cytoplasm, pre-apoptotic status, and even apoptotic status in neutrophils and lymphocytes and activated lymphocytes and giant platelets with speculation. Then we start to observe the changes in the number of the different blood elements, and we clearly could see that we are having lymphopenia in patients with COVID-19, more in cases necessitating ICU admission. And few reports have shown that we are having slight increase in neutrophils, and we were really puzzled. Was this due to the disease itself? Does it have an impact on the outcome of patients with COVID, or is it due to a coincidence of bacterial infection, while the platelets was not significantly statistically affected in cases of COVID-19? This was again confirmed by many studies about lymphopenia, slight increase in total leukocyte count with neutrophils, and again, increased D-dimer titration. And it have been very clear that cases who did not survive COVID have had a statistically significant higher white blood cell, higher neutrophil count, lymphopenia, and marked D-dimer rise. So what we have really collectively in the CBC of a patient with COVID is more tendency for neutrophils increase. And again, we have a question mark. Is it a secondary bacterial infection, or do these increased neutrophils have something to do with the pathogenesis of the disease. We have less lymphocytes, and we definitely have less eosinophils, and a big question mark is basophil. And are all the eosinophils decreased in cases of COVID-19? The red are the cases of COVID, the blue are the normal individual. And you can see clear that there is lymphopenia in COVID patient, while there is marked increase in mean fluorescence intensity concerning CD8 expression in lymphocytes, which means, and it came in conclusion in this paper published by the Iranian physician, that in COVID-19 infection, there is overexpression of CD8, which will hyperactivate cytotoxic T lymphocytes, which will have a lot of consequence later on tissue infiltration in different parts of the body, starting from the lung, ending by any other organ in the body. And this study was reproduced by another paper showing that CD8 T cell increase overexpression does not only occurs with COVID-19, but also it could be an independent predictor of COVID-19 severity and treatment effects. What about eosinophil? We start to hear from Cincinnati, Ohio, and even from China that eosinophils are markedly reduced in cases of COVID-19, and this could have an impact on the patients with COVID-19, and even the Chinese suggested that it could be useful in the CBC to triage our patient, either to be isolated or to be hospitalized, as those who are having marked lymphopenia and eosinopenia could having a higher risk of deterioration of their condition. Coming to the red blood cells, we all know that those patients with COVID are not very much anemic, but those who are anemic are carrying definitely worse prognosis than those who are not anemic. But an interesting publication have documented 7 patients from 6 French and Belgian hospitals who developed a severe attack of autoimmune hemolytic anemia associating COVID-19 infection. So the big question, is it a usual complication? Should we be eager to look for it in every patient with COVID-19? And if we have anemia, should we consider autoimmune hemolytic anemia secondary to viral infection? And the impact on prognosis, we need to see more cases to determine what's going on. Concerning the platelet, as I said before, most of the publications showed that the platelets are not decreased. But in a very nice article, again, showing that in around 7 or 8 studies, the decline of platelet is associated with worse prognosis, and they consider that lowering of platelet count more than around 20 to 30,000 will be associated with increased risk of the disease, increased risk of mortality, and it could be a clinical indicator of worsening illness during hospitalization. Now, we used to ignore neutrophils in the viral infections, and we used to be focusing more on lymphocytes and maximally on eosinophils. But neutrophils and monocytes are having a very important function and a very important contribution in the pathogenesis and affection of different systems, starting by the lung, including others in COVID-19. When we have viral infection, we have activation of the macrophage, and this will liberate IL-6 and IL-1 beta, which will activate the neutrophils, and in the mild condition, it will activate the cytotoxic T cell. But in the severe condition, a lot of matrix metalloproteases and reactive oxygen species and peroxide will damage the cellular wall of the alveoli, and it will enhance fibroblast deposition and a lot of fibrin occurrence and acute lung injury. So we are having an interaction between the different blood cells in the pathogenesis and as a sequelae of COVID-19 infection. Now, the important part of my presentation concerning autopsy. And unfortunately, we have had for centuries a very nice tool to know better about the diseases, the pathogenesis, and how to treat via autopsy. But since late 60s and early 70s, we start to have a marked decline of performing such procedure in all our medical facility globally all over the world, up to a very nice publication in Lancet in 2015, questioning the death of autopsy. And in 2016, another article emphasizes again the importance of autopsy in medical field. And this very nice graph showing that in Switzerland, they are having very mild decline in autopsy formation. And this was associated with markedly declining of the medical associated or medical mistakes or malpractice in medicine. Now, at the start of the disease, we were really impressed by the pulmonary condition of the COVID infection. But people are starting to ask, is it really just pneumonia or ARDS? And a cry for autopsy again to know the exact cause of death in those patients, to optimize the clinical management, and to assess in the timely and effective treatment to reduce mortality. And a call for autopsy have been asked by both physician in the CHEST journal and clinician internist in the Journal of Clinical Medicine to see what's going on. And by the start of March, we realized by autopsy that we are having a venous thromboembolism associated COVID-19. And in this very nice article published by the German scientists, they put pictures for 4 of their patients with marked hypoxia or decreased blood supply to the lung in a gross anatomy, with microthrombi in the lung tissue and macrothrombi with massive pulmonary thrombosis. And they concluded the important role of COVID-induced coagulopathy. And as you know better than myself, that there is a score called sepsis-induced coagulopathy score, and it has been found to be high in cases of COVID, and they are more liable for thrombotic episode. And the evolving story of coagulopathy with COVID have been achieved and established. In my country, since very early of March, we start to introduce anticoagulation for our patients with COVID-19, particularly those with high D-dimer titr, and we start to see cases with coronary infarction, myocardial infarction, coronary occlusion. We saw a couple of cases in my institute with mesenteric vascular occlusion, one of them necessitating surgery. We saw plenty of cases with arterial insufficiency, especially in diabetic patients. And in the last 7 to 10 days, we start to notice many cases starting their symptoms started by leg pain, proved to be DVT in the lower limbs, and with full investigation, the CBC showed lymphopenia. The patients are mildly feverish, and they proved to be positive COVID by PCR examination. So the story of thrombosis with COVID is something to be considered and something to be promptly treated once you suspect your patient and once you confirm the diagnosis. The story didn't stop at thrombosis or thrombotic tendency. We start in a very nice article published 10 days ago in New England Journal of Medicine to realize that we are having endothelial inflammation, which will enhance thrombosis. And moreover, we are having excess angiogenesis in cases of COVID-19. And this is a very nice pathological, again, study from an autopsy patient showing excessive lymphocytic infiltration in the lung with microthrombi, and this is very vascular, again, lymphoid infiltration and thrombus inside the vessel. And this beautiful electron microscopy picture showing excessive angiogenesis, microthrombi, and this is a capillary in the lung of the patient, just para-alveolar, showing heavily infiltration by inflammatory cells. So we are having increased infiltration by lymphocytic cells in the lung. We have excessive thrombosis, we have inflammation, and we have neovascularization. Measuring the angiogenic feature in those patients, it's markedly higher than the patient with H1N1 infection, not to mention comparable to control, and the angiogenic feature count with the more days staying at the hospital, the worse the condition of the patient, this angiogenic marker is rising. Moreover, the expression of angiogenic, when they start to examine the genetic genes from the lung of the disease of the dead patient, in COVID, they found a lot of genes which have been mutated, comparable to H1N1, and most of these genes will affect angiogenesis in those patients. So practicing of anticoagulation, particularly those with elevated D-dimer, have been adopted worldwide, and moreover, there have been reports of 3 cases from the United States of use TPA, tissue plasminogen activator, in treatment of COVID-19 associated with respiratory distress syndrome. And one of these cases showed a marvelous response. In the last week, we have tried that in one of our patients with a severe condition, D-dimer titer over 5,000, and the patient showed slight improvement, and we hope in the coming few days to see more improvement in that patient. So it's not only the endothelial lining of the blood vessels in the lung. We have vascular endothelial inflammation everywhere in the body, including the coronaries, the mesenteric, the peripheral, the cerebral, everywhere in the body. And another point back to the neutrophils, which I said, is it response to bacterial infection, or do we have something else? We don't know. A question in late April about the role of neutrophil extracellular trap, which we call them NET. Could it have a role in pathogenesis of COVID? This was followed a couple of weeks later by another paper showing that the thrombosis is there in COVID-19, but the exact pathogenesis is unknown. And that's why they measured the NET and neutrophil activation in COVID-19 patients, and they found a higher level of NET and calprotectin in those patients. And they assumed that NET, increased neutrophilic extracellular thrombosis, could have a role in pathogenesis of COVID-19. Then we have 2 very important papers which have been published this month. The first showing that targeting neutrophil extracellular trap could be of help. Why? Because NET formation will cause excessive mucin, mucus formation, and fibroblast and fibrosis and ARDS will increase thrombotic events and will increase atherosclerotic. This is what we know. And this is a beautiful electron microscopy picture from the lung of that patient with COVID-19, showing extensive NET formation in the tissue of the lung of this patient. And this is another picture of trachea showing massive infiltration with NET formation. And this is from the lung, massive neutrophil infiltration and the increased NET formation, which have been proved by histochemistry by electron microscopy. This is the other patient showing again increased DNA, neutrophil DNA, and this was parallel, having linear relationship with C-reactive protein, D-dimer titer, LDH, and neutrophilic count in those patients. Concerning NET formation, it was quite high in patients with COVID, comparable to control. What was interesting is incubating plasma of normal person with neutrophils show very minimal netosis, while incubating plasma of COVID-19 patient with neutrophil showed marked netosis even in lab. So this is a real important contributing pathogenic effect which have been identified by autopsy, and many postulation to stop this netosis and to target that by either stopping macrophage activation by stopping DNA's macrophage activation of the neutrophils, or stopping neutrophil elastase by elastase inhibitors, or giving colchicine to stop activation of neutrophils, or to stop IL-1B induction by NETs. To sum up, these are the pathophysiological changes which have been known or identified or seen by the eye in the lungs, and these are what have been seen in the eye by autopsy in the cardiovascular system, while hematological system, we have seen that the spleen is affected in those patients with COVID-19, and there was depletion of white pulp, And in another paper published again by the Chinese showing that the T and B lymphocytes in the spleen are markedly decreased, the lymphoid follicles are atrophied, decreased, or even absent, while the natural killer cells are not changed significantly. Again, perivascular, periportal vein and perihepatic vein infiltration by lymphocytes have been identified in liver in COVID-19 patients, and this could be direct viral-induced or hepatotoxicity from therapy. Renal affection, again, have been identified, and marked infiltration have been shown, and changes in the tubule and the glomeruli of patients with COVID-19. So no system is immune. Lungs, heart, spleen, liver, kidney, GIT, which could be the first symptom. Many cases with Guillain-Barré and other neurological, including loss of taste and smell, and many cases with skin affection, vasculitic changes, and even Kawasaki vasculitis have been reported beside the hematological changes, which are well known. So COVID-19, we need to navigate our road. We are still having 3 unknowns up till now. We need to know more about the depths of the disease, the real pathogenesis, the length, how much the disease will stay with us. Most importantly, are we going to have a second or a third wave of the disease, and the shape of the recovery? We need to know more. Our learning curve is rising, but we need to know more, and we need to stay afloat till we find solid ground. With that, I finish my presentation. Thank you very much.
Anna, thank you very much for your excellent and very nice presentation.
Thank you, sir.
I would like to remind you again that I'll take all questions that you have after we finish the presentations. And we move on to the next speaker, Dr. Sasha from Poland. Hi.
Hello,
Dr.
good afternoon.
How are you? Good afternoon. Yes, please.
So thank you very much for the organizers for inviting me to this very interesting meeting. I'm very happy to see you all here. I come from Krakow, which is located in the southern part of Poland. And I'm head of the hematology department with bone marrow transplantation unit. And I will tell you a short story about the situation with COVID in Poland and what kind of the preventive measures we introduce in my department just to minimize the risk of COVID. So Poland is a country with a population of 38 million, with life expectancy around 80 years, and with the median age of our citizens is quite low because it's about 40. So the pandemic starts in Poland at 6th of March, and after 1 week, the government has closed all schools, kindergartens, universities, courts, and shops, except for elementary shops, of course, and the country was closed, except for Polish citizens. At that time, the special flights were organized for Polish citizens who want to come back to Poland, and a lot of Polish people came back from UK, Ireland, and Germany, mainly because they have been afraid of being abroad, and partially because of them, they don't have the health insurance. So after coming back to Poland, they were sent to 14-day quarantine. After 1 month approximately, we were forced to use the fashion mask. So that was the huge debate, but finally the government decided to ask us to wear a fashion mask. Now I will try to share with you some data from the current situation in Poland. I hope you could see it. So currently we have 23,500 of cases with 1,000 of deaths, with 11,000 of people recovered. And we don't have any plateau. So this is logarithmic scale, which is showing that actually we have some flat part of the curve here, but still we have some new cases. And as I watch the television channels and all the official statements. We have around 300 to 400 cases daily recognized as the new cases. So we don't see any reduction of the new cases. So we are far from the extinction of this pandemic. So the current situation is that government has decided to release some activities. So the shops, markets, malls, churches are open since a week with the regulation of having not more than one person per 4 meter squares. And the same is for barber shops and beauty salons with some recommendation of social distancing. Starting from the next week, we will able to go to cinema and theaters, museums, and of course the social distancing will still be recommended. But the pandemic is not slowing down. We have some focuses of outbreak. One region with the highest incidence of COVID is in our neighborhood in Silesia. This is a very industrial region with a lot of big factories, coal mines, and the coal miners are currently the population most affected by the COVID. In Krakow, we are the city with almost 800 citizens and 800,000 citizens. Some investigations have been done by the researchers of our university. So they tested 1,000 of asymptomatic people, and they found that 2% of those have been positive for COVID. Regarding the hospital I work, we are the part of the Covd hospital, which is the largest hospital in Poland. We have almost 1,000 of beds. However, our department, fortunately, the hematology department is located in a distinct location, so we are separated, and we have 12 transplantation beds and 30 hematology beds. In the COVID hospital, in the peak time of admission of patients, we had around 120 patients hospitalized due to COVID. In the same time, the doctors have been taking care of 300 patients. They have been in quarantine at homes. So the average admitting rates per day was about 20 patients. But since 2 weeks, the number of admitted patients to our hospital is lower than the number of patients discharged from the hospital. So the situation is being improved, and several wards are coming to the normal activity. Well, regarding the hematology department, we're closed, of course, for visitors, including family members, students, pharma representatives, other doctors who normally visit us to have a training since the beginning of March. In Poland, we have the situation where the majority of doctors and nurses are working in several places, including emergency units, care facilities for elderly people, etc. So they all have been asked by me to stay at hematology department only as a single workplace. So currently all doctors, all nurses, cleaning and support staff have single workplace in my department. Unfortunately, there is no financial support from the government for those people. They have resigned from the additional workplaces. So the second regulation I've introduced is the rotation of the work. So the nurses and the doctor staff is divided into 2 parts, and they work the 1 week in order to avoid the spread of the coronavirus. So we always have some backup people at home. They could come to work if needed. So they have access to the medical records of our patients, and they are able to help with the administrative work. They do the telemedicine visits in our patients. So before coming to work, those people I wanted to test, even if asymptomatic, but the hospital limited the number of tests for the personnel for 7 per week. Fortunately, those tests have been negative, and currently we are testing all the people, they have some risk of contact or some risk of being infected. As far as testing is regarded, we have the PCR-based test since the beginning of the pandemic, with the waiting time for the results ranging from 6 to 12 hours. Sometimes it takes 24 hours if the laboratory is very busy. Since 3 weeks now, we have a fast test available, which is PCR-based. And this is done on a GeneXpert platform, which is used for BCR-ABL estimation as well, with a waiting time of 45 minutes. And this test is used by the emergency unit and on my request to our patients in some emergency situation. Since 2 weeks, we have a Roche test, which is serologic test available as well. And the all personnel of COVID wards, they have been engaged in the care of patients with COVID, have been tested. And I have to say that after 700 tests, only 4 were positive. So indicating that the contact probably was very low and the immunity is very low. Regarding patients admitted to our department, we have introduced the procedure where the patient is admitted to the separate room, and the test for COVID is done. The personnel is protected as if the patient would be positive. And of course, during that time, the minimal number of medical procedures are done. And after the negative result is coming, the patient enters the ward for chemotherapy and for other procedures. So because of the limited places, of course, in my department, we had to limit the number of admitted patients to 4 per day. As far as transplants are regarded, we have stopped with autologous transplantation for multiple myeloma for a month, but since a week now, we started this procedure again. And the other procedures are running as usual, including the MATs. We received last week 1 material from Israel, 1 material from Germany, and those patients are just under the treatment as it is recommended by EBMT. Of course, the material is cryopreserved in those patients from the donors. Patient admitted to the day clinic before visiting, they all received the calls and have been asked the question regarding the COVID, about the contacts, travels, symptoms. And if they come, the epidemiological survey is distributed and checked by the medical student who is measuring the temperature before the entrance into our department. And additionally, this person is taking care of the distancing of patients they are awaiting for the visits. Unfortunately, our hospital did not accept my request for having additional person who could take this duty. So we are asked our students, and they are helping us with this situation. If the patient will have some risk of COVID infection, we have prepared a room outside the clinic where the patient is taken and is examined by the doctor with all preventive measures, of course. And after testing, the patient is either sent home or to the ward, which is dedicated to COVID patients. So 80% of work in our outpatient department is done by the telemedicine at the moment, since the payer accepts this form of medical visit. And last but not least thing, what we have observed as I think as a result of those regulations, mainly due to the visiting restriction, I think, but of course all factors have its contribution. We see about 90% of reduction of fever and infections in our hospitalized patients. So there was no septic shock, no death related to severe infections since the beginning of March in our department. So, of course, I have issued some information for the patients and for the patients' families just to understand this situation, to understand these restrictions. And we are trying to maintain those regulations. However, we have to be aware that this situation will be, in the case of our country, probably the long-lasting situation, and we are expecting the second wave of the COVID infection in the autumn, when the spread of the influenza will arrive. So that's all from my side. I hope it was helpful for you. Thank you very much.
Thank you so much, Thomas, and for your very detailed explanation about Poland. And next speaker, also Dr. Nikolai Tupisin from Russia. Hi, Nikolai, how are you? Can you hear me? Okay.
You hear me?
Yes. Yeah,
okay,
yeah,
so
I can
let's
hear
start.
you. Thank you. You have 15 minutes. Thank you so much for the presentation. Okay.
So as we are a little bit late, I will try to some slides so to be not so long. So first of all, I am very grateful for organizers for inviting me to this meeting. So, and dear colleagues, as you know, my specialization is not COVID-19. I am working in Cancer Research Center, Moscow, Russia, as a head of Hematology-Oncology laboratory. In our studies, we sometimes use immune adjuvants to see its influence both on tumor cells and immune parameters. That results are very well known, as were presented several times at our conference, International Hematology, which participants last 6 years are Birol, Onur, and other Turkish and not Turkish colleagues. So one of those immune adjuvants, just a moment. Yes. Called polyoxidonium seems to be interesting. By the way, it is used in infectious diseases and in COVID-19 as well. So my talk will be mainly about it. If you permit, I will jump from some general slides as introduction to the particular ones, which are clearly related to the, so to say, topic of the report. Yes, it's this. Yes. Just a moment. Where I should start? 11. So you can see, for example, that cytokine storm accompanied by a sharp increase in ILCs is, in most cases, precedes the death of patients with COVID-19. And its specific treatment strategies are now get rich with new data, mainly with the use of specific anti-IL-6 blocking antibodies. Anyway, it seems that potential immunosuppressive mechanisms prevail, or at least exist, in patients with COVID-19. The concentration of IL-10, the most immunosuppressive cytokine in the body, is elevated, which leads to the conclusion that therapeutic approaches that include activation of the immune response might be needed. There are some data of Chinese, so to say, scientists and clinicians about the role of comorbidity. I will not put on it carefully, so to say, sorry. The patients, okay. The SARS-CoV-2 virus infection goes through all the stages of viral infection subsequently. So it's infection, activation of antigen-presenting cells, activation of the cellular immune response, activation of humoral immune response, resulting in production of antibodies. Activation of RIG-1 and MDA5 is the cornerstone of initiating the antiviral immune response. MDA5 in humans is inducible molecule. MDA5 activation makes a significant contribution to viral RNA recognition and in early recognition conditions, early activation of the immune response. MDA5 induces a more robust type 1 interferon response that weakens viral replication and infection in vitro and in vivo. So it seems reasonable that elevation of MDA5 may be beneficial during viral infection. In fact, as I promised to tell you about Russian immunoadjuvant polyoxidonium, we should state that this compound, azoxymer bromide, highly elevated the levels of MDA5 expression. Antigen presentation is one of the key steps during viral expression, and one of the early events is the activation of antigen-presenting cells. We've performed an experimental study together with French colleagues from INSERM, Martin Vilaba, to see the influence of polyoxidonium on dendritic cell maturation. It was proved, and data were just published in Frontiers in Immunology. Neutrophil release, neutrophilic extracellular traps, so-called nets. Hanan Hamed already mentioned this new mechanism in her report, and I am very grateful for her for this. That nets, which mainly consist of DNA and histones. That release is now called netosis. It's a newly, just in 2004, described mechanism of antimicrobial action of neutrophils. Experimental data suggest that it is mainly active against bacteria and protozoa. The negative effects of netosis is in that it bind and activate platelets to enhance blood coagulation. It was mentioned in the report of Hanan Hamed. Scientific Society consider netosis as a potential therapeutic target in several pathologies. So the compounds capable of diminishing the formation of nets is a serious problem. The study of influence of polyoxidonium on net formation was done on neutrophils of peripheral blood of healthy donors. Intact neutrophils do not form nets. Stimulation with PMA leads to active formation of nets, clearly seen nets of neutrophils. You can see these nets. While treated with polyoxidonium, neutrophils form almost no nets. It is of high clinical significance because there are almost no any compound capable to correct net formation. Another interesting molecule in context of stimulation or enhancing antiviral immune response is ICOS ligand. ICOS promotes T-cell B-cell interaction and the production of high affinity antibodies by B cells can enhance the antiviral and anti-tumor activity of the immune response. As you can see, expression of this ligand, CD275, is highly elevated after PO action. Polyoxidonium increases the expression of ICOS-L by 1.7 times. And now let's come to the antibody production, one of the most important mechanisms of antiviral defense. On the slide, it is shown as the last in the list, but this is not so. To understand this part of my report, let's come to the quite old data from the mid-19th of the previous century. That time, PO was just synthesized and the experimental data were very carefully performed on experimental animals, mice. The very good paper review on experiments with PO was published in our journal Hematology-Oncology in Russian and in English. Administration of PO together with corpuscular antigen chip erythrocytes was shown to induce 2 to 4-fold increase in antibody forming cells. PO administered in complex with this antigen recovered immune response in old and nude mice. So I don't say it's important is to increase the antibody response in old, so to say, individuals, because it's a risk group. A similar recovery effect was observed in animals with experimental X-ray or cyclophosphamide-induced immunodeficiency. I should say that these data were performed about 25 years ago, so at that time nobody thought about COVID-19. So it's not just just adjusted for this situation. No, it was much earlier. Immunization with soluble antigens, influenza virus, hemagglutinin in complex with PO led to enhanced antibody synthesis in low response within lines by almost 4.5-fold. Maximum stimulation was observed as a result of conjugation of influenza virus with PO. Antibody synthesis in CBA mice demonstrated an almost 40-fold rise. Not less interesting data demonstrates next diapositive. PO increased immune response both in complex and in conjugation with antigen. Immunization of mice with PO conjugate with recombinant heat shock protein HSP70 used in tuberculosis vaccines led to almost 40-fold rise in antibody synthesis. 40-fold rise. Petrovax, it's a Russian company which produces PO, launched an international clinical study on polyoxidonium for the treatment of hospitalized patients with COVID-19 in Russia. Polyoxidonium, azoxybromide lyophilizate for the preparation of an injection solution 6 mg is approved by the Ministry of Health of Russian Federation for conducting an international multi-center placebo-controlled clinical trial of phase 3 in treatment of hospitalized patients with COVID-19 in Russia. I will not tell you all the particular things of this. So, IMCT is conducted in accordance with international standards. International multi-center double-blind placebo-controlled clinical study of polyoxidonium for the treatment of corona. As of May 27th, 76 patients were randomized in 6 sites. Open-labeled observational study and IMCT in Russia, an open-label observational study of the use of polyoxidonium in hospitalized patients with COVID-19. As of May 26, 97 patients are included in the study. Information about 50 patients was filled in. Of those 50, so I will not tell you these preliminary results, so they are good, but we will wait for the final results. Okay. It should be mentioned that polyoxidonium is included in the clinical guidelines for the treatment of patients 65 years and older with COVID-19 in Slovakia. Data yet to be analyzed. In fact, polyoxidonium has been registered in Slovakia since 2008 and has been used in routine clinical practice for more than 11 years. Here you can see that polyoxidonium is included in the temporary guidelines for the treatment of SARS and influenza during COVID-19 in Russian Federation. And here you can see the potential immunoprophylaxis of COVID-19 in individuals. So it's 27. Yes. With high risk for infection, 2020. Just a moment, just one moment. Sorry. I should emphasize that polyoxidonium in immunocompromised patients with infectious disease, including patients with pneumonia, has been widely studied in Russia. And by the end, some more information on polyoxidonium. Polyoxidonium is an immunomodulating agent that has a range of properties: immunomodulating, immunoadjuvant, detoxifying, antioxidant, and moderate anti-inflammatory. The drug increases the body resistance to local and generalized infections of viral etiology. Side effects are not registered. Polyoxidonium has been widely used in clinical practice in Russia for more than 20 years and is also exported to other countries. Currently, the drug is registered and shipped to 10 countries. In 2017, the drug underwent a post-registration safety study in the territory of European Union, Slovakia, post-authorization safety study PASS. Here are some forms and treatment schemes of polyoxidonium. Some more information about it. I think that if it will be interesting, so okay, sorry. Return. Yes, it's okay. And this is okay. And thank you very much for your attention. If there is some interest, I can give you via Anur the contacts of Petrovax personnel. Thank you very much.
Okay, thank you very much, Nikolai. We are extremely late, so I would like to take only one questions coming from Vera Donenberg to Dr. Sevgi. Sevgi is over there, or Sevgi, can you hear me?
Yeah.
Okay. The question is about the dream therapy in COVID era. The question is, what would you be your dream treatment? Your dream treatment? Maybe we can ask this question to the other speaker also. Thank you so much, Vera.
Okay, thank you. I thank also to Vera. My dream treatment would be a persistent immune response, such as smallpox, who announced that smallpox is eradicated from the world. So my dream would be a persistent immune response, a good vaccination protocol would be. I am not looking for a drug. I am looking for a persistent immune response.
But unfortunately, it depends not on us, it depends on virus, maybe because of the risk of the mutations and something like that. I hope that we can cure the diseases.
The mutation can be, but some antibodies can cover the mutation.
Yes. Yes. Thank you so much. Any other? Okay, then I cannot take more questions because we, as I said before, that we're extremely late. So we have 10 minutes break, and then Albert will lead the next session. Thank you so much for the attendance.
Thank you very much.
Thank you.